Hello, and thank you for joining this OncLive TV peer exchange. This program will feature expert panel discussions highlighting therapeutic advances in renal cell cancer and key case studies in community oncology practice. My name is Bob Figlin, and I am a professor of medicine and biomedical sciences and chief of the Division of Hematology Oncology at Cedars-Sinai Comprehensive Cancer Center in Los Angeles, California. Participating today on our distinguished panel are Jan Dutcher, Associate Director, Cancer Research Foundation, immediate past chair, ECOG Renal Cancer Subcommittee, and founding member of the Cytokine Working Group in New York. Chuck Henderson, Peachtree Hematology Oncology Consultants in Fayetteville, Georgia. Danny Heng, Clinical Associate Professor, University of Calgary, and a staff medical oncologist at the Tom Baker Cancer Center in Calgary, Alberta. And Brian Rini, Professor of Medicine, the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University in Cleveland, Ohio. Thank you again for joining us today, and let's get started. Real-world outcomes in metastatic kidney cancer, the role of targeted therapies in community oncology practice, will be the focus of our first discussion. So let's start this, Chuck, and jump right into how do you think about choosing a first-line therapy for the patients that present to your oncology practice in Georgia?
Sure. Well, first of all, we assess clinical features of the patient. Does he have an intact primary, where we consider a cytoreductive nephrectomy? Does he have CNS metastases, where we consider neurosurgery or radiation? Is the patient young enough and healthy enough to consider interleukin-2, which we still regularly refer for that population? Apart from those considerations, we look crudely at the MSKCC risk criteria. Almost all of our patients fall into the low risk, and up until 2 years ago, our main approach was a clinical trial. For 10 years, we did clinical trials of first-line treatment of kidney cancer. Most recently, we participated in the COMPARES trial of pazopanib versus sunitinib. After that ended, we no longer have a trial. So our bias is a bit toward pazopanib based on the COMPARES trial and the PISCES trial from Dr. Escudier, which showed that patients preferred pazopanib because of fewer severe side effects.
So would you say that in your practice, your clinical experience mirrors that as reported in the literature?
I think so. I think pazopanib is a little bit less toxic than sunitinib, although with the reservation that appropriate dose modifications of sunitinib can work very well.
So Brian, you have an interesting abstract at this ASCO in 2014 that says that maybe not all metastatic kidney cancer patients need to be treated as soon as they're found to have metastatic disease. Can you tell us a little bit about that data and how that might inform the choice of when to start therapy?
Sure. So, in all of our clinical practices for years, there's patients who have very indolent disease. I often describe to patients that kidney cancer is the most biologically diverse disease out there, from patients with very indolent disease over years to patients who get worse right before your eyes. For that subset of patients with indolent disease, which I would estimate is maybe 5 or 10% of patients, we decided to prospectively study them because there's case series and retrospective data, but that has limited utility. So ourselves, along with other institutions around the world, did a prospective trial where we took these indolent patients, which was really a clinical decision by the doctor that these patients didn't have a high tumor burden, maybe had a scan or two while they had metastatic disease to know they had indolent disease, didn't have symptoms, of course, things like that. Not that they were too sick to be treated, but just that their disease biology didn't require treatment. And then we followed them prospectively with scans every 3 months per year, then every 4 months, then every 6 months. And what we've reported here and initially found is that the average length of observation from when we started watching them to when they initiated treatment was about 14 months. So well over a year. Now, obviously, that decision to start treatment was entirely made by the treating physician and or patient. So it wasn't a firm endpoint that you had to treat people at a certain tumor volume or certain pace or anything like that. It was just a clinical decision, which is, of course, how we do it in practice. So it gave us some reassurance that in this subset of patients, you can watch people, often for a long time. There's 3 patients we've watched over 4 years.
So I think one of the things that would be helpful is, kidney cancer predominantly spreads to the lung, and it's easy to imagine that there's an indolent disease with small volume pulmonary disease. Tell us about the other patients, though: bone, liver, soft tissue. Did you find some of those patients you could follow as well?
Yeah, I mean, the population is a pretty typical kidney cancer population. The age was a little bit older, it was 67, but other than that, it was clear cell and prior nephrectomy and typical sites of metastatic disease. We haven't yet broken down sort of by metastatic disease site to say, gee, the lung patients we can watch longer than the liver patients, et cetera. And so as we start to dig into the data more, we'll be able to do those kind of analyses, although it was only 50 patients, so as you start to get the subgroups, it gets a little small.
And this was primarily a clear cell population. Mm-hmm. Do you think that your observations apply to the non-clear cell histologies, or do you think it's yet to be determined?
I mean, I would say probably. There was 2 chromophobe patients. Those are the only non-clear cells. All histologies were allowed, so it wasn't intentional that we didn't enroll papillary. It just didn't turn out that way. But I would think so. I mean, indolent disease is indolent disease, whatever the underlying subtype is. If it's growing slowly, it's growing slowly.
So now in the current environment, in making your decision about when to initiate therapy, we heard from Chuck some of the classical risk factors associated with when to start. Is that pretty much how your practice has evolved?
Yeah, I mean, I think we look at, burden and pace of disease. We think about risk factors, Danny's risk factors in the MSKCC, and just kind of that gestalt of, does this patient require immediate treatment? Some of it, frankly, is the opportunity for clinical trials. If we have more exciting trials open, we may lean towards earlier treatment, or if not, we may defer treatment until that time. So there's a lot of factors, but those are some of them.
Yeah, and Jan, there was a